Good afternoon, everyone, and thank you for joining us for the Overdose Prevention Engagement Network webinar. Welcome to today's session, Person-Centered Substance Use Disorder Care, Screening, Harm Reduction, and Support Strategies. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on the Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBath credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. So my name is Katrina Hernandez. I am an engagement specialist with OPEN, the Overdose Prevention Engagement Network, and I will be monitoring the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBath credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication and storage disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes and for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machine and distribution boxes, and also naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. Our presenter today, Eliza Hutchison, MD, FASM, is board certified in family medicine and addiction medicine, and currently is an assistant professor of family medicine at the University of Michigan and medical director of addiction services at Packard Health, a federally qualified health center in Ann Arbor. She is also an educator and clinical consultant for OPEN. Prior to living in Ann Arbor, Dr. Hutchinson provided primary and addiction care at federally qualified health center in Seattle, Washington, and served as clinical site director of a low-barrier community-based model for substance use disorder care. Dr. Hutchinson is a passionate advocate for expanding primary care-based addiction treatment, rooted in harm reduction, improving the health of individuals affected by incarceration, gender-affirming care, and stigma reduction.
thank you so much for the introduction, and thank you everybody for joining us during your lunch hour or whatever you get as a lunch hour. Really appreciate the chance to be with you all in our lovely virtual setting here. And sort of, two pieces that I just want to share as we get started. First of all, although the interaction piece is hard, but I love getting to hear from you all as we go through, either in the FAQ, and then we'll try to answer those questions at the end, but also suggestions, other insights. I love learning from any of these presentations that I do, and it gives me, information about what we need to share going forward, and information I can pass on to other audiences. So thank you in advance for your thoughtful participation. And number two is sort of just, acknowledging again, of course, that we are all in a really uncertain and changeable time right now, and everybody is being impacted differently. And I just want to acknowledge that we have an amazing set of multidisciplinary professionals here in our virtual room. Everybody from social services, public health, government agencies, corrections, clinicians. I think we really together we're the network and the ecosystem that is already providing this care and is going to find a way to do it as we go forward. So just appreciate you all being here. And what I'm really going to try to focus on again is, funding environments change. It's just, things that we can do that don't require funds, don't require extra money, right? But just that we can do in our own interactions with individuals who use substances going forward. So with that, we'll move forward. These are the main objectives we're going to try to cover today. So thinking about just sort of some best practices to identify substance use disorder, which I'll just call SUD as we go forward. Some specific strategies that we can use to best engage folks with SUD in care. And again, whether that care setting is sort of the social service sector, whether that is clinical. Again, my lens is of course clinical, but I hope that what I'll share will apply to a lot of different settings as well. And then talking about harm reduction principles and how we can implement those in our clinical encounters with individuals. And again, I'll probably say patients a lot since I'm a physician, but can think of it as patients or clients, sort of depending on your setting. So first, as always, just sort of stepping back, why are we here? Why are we all spending our lunch hour together? I think we all probably in this room know more or less this graph, and that overdoses and drug-related mortality really through 2024 were skyrocketing. As we see the little gray line that's almost vertical there around 2019 through 2022, very much driven by fentanyl and other related synthetic opioids. We were seeing those numbers increase really all the way through 2024 to exorbitant levels that we all have heard about in the news or wherever we're working. We also probably have all heard that there has been some really promising news more recently, sort of over the last year, as states, including Michigan, have seen overdose deaths dramatically decline, kind of between 15 to 30%, depending on where you look. So this has been a really promising trend that we can certainly follow and celebrate and gain some hope from. We'll also say, though, as probably isn't surprising to anybody here either, not everybody was sort of equally affected by some of those trends, right? And we certainly saw that even as overdoses nationally and in Michigan dropped for most groups, those among AIAN populations and Black populations really were not declining in the same way. So just kind of important to remember as we celebrate those wins that everybody is differentially affected. But as we think about sort of why these trends are improving, right, because they are exciting, and it's hard to parse out, one specific intervention, and probably no one specific intervention has really been making the difference. But certainly what a lot of people think are, the expansion of naloxone, sort of in that harm reduction realm, and medications for opioid use disorder are some of the key strategies that really have made a big difference. So again, these are really powerful tools that are at our disposal in all of our roles. But despite that, a lot of people still are not receiving that care. And so, we're really going to focus on if we want to utilize these tools to their fullest extent, we first need to find a way, of course, to identify and engage the people who really most need them. Because although SUD is very common and it is very treatable, it remains highly undertreated. And this goes for all substance use disorders. The stats I have over here on the right are for opioid use disorder, because these are some of the most profoundly impactful with treatment. So we know that if a person with opioid use disorder is on what we call an agonist medication, buprenorphine or methadone, they are more than 50% less likely to die of an overdose on any given day. So very much a life-saving treatment. But despite that, still, with all of our efforts, only 1 in 4 people with opioid use disorder has received one of those evidence-based medications. So we still have a long way to go to get this care to the people who need it. And so why aren't people receiving that care? Of course, there are a million reasons, and I have listed only some of them here. And I kind of think of these in buckets of sort of the individual factors, more medical and social service system factors, and social determinants of health. Again, this is not an exhaustive list. But today we're really just going to focus on a few. And again, these are ones that I think don't require any specific additional resources really to do. This is about how do we understand the people who are presenting to us and how do we best engage them to then be able to down the line offer evidence-based care. So what we're really going to try to address is sort of on the individual level, understanding how trauma histories play into the way that people present in care, the history of fear and stigma, and then mistrust of medical and social service providers, or where that comes from and how we can address it. And then again, sort of on the medical and social service system factor level, thinking about, some of the additional education, which we're all pursuing today. But again, this is, not yet really standardized in, for example, in health professions education. And we still probably are not quite getting there with our screening and diagnosis. And so again, we're going to talk about how to do the engagement piece and appropriately screen. So first and foremost, again, we can't do any screening, we can't do identification, we can't treat if we cannot first figure out how to engage, bring people into care, interact with us. So that's what we're going to talk about very first off. And I like to just sort of step back and think about, again, what is the story of people who are showing up in care, right? Or people who are using drugs. Oftentimes, right, these are people with intersectional, overlapping, stigmatized identities, and these are just a couple of those identities, right? But many of our clients or patients are living in these very oppressed categories that really color their experience and then color the way that they will interact with care providers. So, I work a lot with unhoused populations, right? These are people who are every day triaging their basic needs. They've often had a lot of negative experiences with health and social service systems in the past. Folks who are racial minorities, who of course have had a lot of historically unfair treatment by the medical system and thus have pretty well-founded mistrust. Oftentimes might be lower socioeconomic status, again, trying to meet basic needs. Folks who've been involved in the carceral system, who again have had often negative experiences with healthcare, either during incarceration or outside of that. And particularly in the very chaotic, high-risk time of reentry back to the community, a lot of, triaging basic needs again, things that are gonna, potentially interfere or impact with their ability to and willingness to engage in care. Just sort of the way that I think about this again is with these histories and these experiences people have had, they're oftentimes bringing really well-founded mistrust, experiences of trauma in the medical system, and feeling really stigmatized in society and in the medical and social service systems. And, so that's just important for me as a medical provider to know, because that's, it's gonna shape the way that they show up and access care. There has been, good documentation, and this was a survey out of Washington for people who are using drugs, but a lot of people, again, do need medical care. They know they need medical care, but they choose not to seek it. And, the reasons aren't because they don't want to take care of their bodies. Their top reasons are, number one, they don't trust or like doctors, and two, they don't want to be lectured or feel judged about their drug use. So again, these are factors that's really going to shape whether we can engage with people enough to offer them the care that is going to be life-saving. This is just highlighting again, this is another survey of residential patients with SUD. And people were just asked to describe their experience with medical care. And of course, in these little word clouds, the largest words are the ones that are most commonly cited by participants. Again, so stigmatizing, uncomfortable, disrespectful, upsetting, demeaning. And again, for all of us who are here, these are probably, we are probably aware of these, and we're trying to do our best to change these experiences. But this is often the experience that people are already bringing with them. I also like to think about, again, this is me down in the corner as a happy, excited resident about 10 years ago when I had more energy. But this is a picture of how I think about when people are trying to access care, and this is specifically medical care, but we can think about it for social services or lots of other care as well, right? So many steps people have to take to get to us. They have to find transportation. They have to make it to a clinic, usually on time for some kind of appointment. They have to go through an entire check-in process at a front desk. They have to have their health insurance card. They have to fill out a giant stack of forms that are maybe intimidating, maybe difficult, depending on literacy levels. So by the time they've done all that and then they get to me as the provider, right, it's already exhausting. It's already pretty heroic that they've made it that far. And when I think about, again, layering on that historical mistrust, the feelings of stigma and trauma, this is a huge ask for people to get to come and see somebody like me. So for me, I need to think about, even though I look really friendly, I think, and welcoming, right, that may not be how somebody perceives me. And so I just, as a medical provider, need to be very aware of that. And there are ways I think that I can mitigate that in the way that I interact. So when we think about, again, sort of from the medical standpoint, taking a history, but again, if you're a social worker, if you are, working in a different sector, there are still a lot of these pieces you can bring to your interaction. And again, these are fairly basic and probably many people have learned about them, but I think they're really important to review and think about. First of all, just always remembering over there on the right, those identities of patients, right, that they really have probably moved through the world feeling highly oppressed and stigmatized for a lot of their life, and that they often have had very negative experiences in the healthcare or social service system in the past, and it's our job to contend with those. um, so I think first of all, when I'm walking in a meeting with a patient, are they physically comfortable as much as can possibly be, right, in an intimidating exam room, right? Do they have access to the door if they need it? If they want to stand and move around, maybe that's better. If they want to sit, maybe that's better. Try to always ask permission to ask questions, right? Very easy. I'm a doctor. I'm taught to just pummel people with a million questions, and I know why I'm asking them. They don't usually know. So important for me to ask permission, let people know if they want to not answer a question, that is okay, and help them feel empowered about the information they want to share. For me, explaining why I'm asking questions, right? Many of the things that are relevant to that patient's care are oftentimes feeling really invasive and people don't necessarily understand why. So really helpful if we can explain, why I'm asking details about their sexual history or why I'm asking details about their substance use, and how that's going to allow me to help them and that I'm not just asking it just to ask. Trying to be really explicit about what I'm doing over at the computer, right? Especially if we think about, populations who've been involved in the justice system for a long time, maybe don't know if they were incarcerated 30 years ago and there was no electronic health record. They don't know that I'm just not over here, Facebook chatting or whatever I'm doing. I dated myself by saying Facebook, but whatever I might be doing on the computer, right? They don't know. So important for me to say, that this is like where I'm documenting your medical information so we can take the best care of you as possible. And, just letting them know sort of how that gets used and why I'm over there typing. Encouraging people to ask questions or interrupt me if I'm just going on and on. And obviously, as you can already tell, I'm a fast talker, so making sure I'm pausing, empowering that patient to say, "Wait a minute, I'm confused. Please explain that in a different way." Um, Early on, really important to, understand what my patient's goals are and what their concerns are. Of course, kind of from it coming from whether it's like general primary care or whether it's an addiction medicine standpoint, I have a lot of goals in mind that evidence tells me should be the goals for that patient, but they may or may not be that patient's goals today or in general. And I'm going to do best engaging with them if I can understand what their goals are and hopefully connect them to some of the evidence-based ones that I know also are out there. Um, I try to really clearly express sort of my care philosophy, in the world of substance use treatment. I think about this a lot, specifically with, if I'm doing urine drug testing, explaining to the patient what I'm doing with those results and how that will or won't change their care. And for me, this is very much sort of a harm reduction philosophy, that, I'll state explicitly that a patient isn't required to be abstinent to continue care with me. Those kinds of things I will really try to share with people right up front. And then using clear person first language, again, as we are all trying to do, but this is hard to do. And I keep a little poster up in my office, even though I think about this and talk about this all the time, but just to remind myself to do my very best to use person first language. And then sort of in that yellow bucket of things to try to avoid, again, avoiding stigmatizing language. If a patient just is really reluctant to share some information, I try really hard not to press for it right then. If I think it's important for their care, I'll try to revisit it later in a different way. But if it's not absolutely vital that I have that information, I try not to press for it at that time. If somebody does have justice involvement, which of course very common in this population, I do try to learn if there are things that get them reincarcerated that I can help with. For example, helping treat mental health conditions, helping treat substance use disorder, but not learning about details of their criminal charges. Again, that can make somebody feel uncomfortable, but it can also trigger my own implicit bias and how I might treat them in the future. So these are sort of the things that I'm trying to think about as I go through these encounters, whether it's the first encounter with a patient or a subsequent one. And a couple of resources. So over on the right is a wonderful Curbsiders. If you ever listen to this podcast and you're a medical provider, this is a really wonderful one about how to do this history. And then these QR codes are actually, these are Chalk Talks, sort of brief little drawings and videos that I have made for various medical learners that can also talk about some of these strategies that I've just gone over. And these will be available later for people as well. So now that we've just thought a little bit about how are we generally going to approach patients, let's just talk for a moment about screening. There are many, many ways to screen, and this really is variable based on the environment that you're in. So I'm going to just sort of give an example for a medical setting, but again, you want to tailor for your own environment. But I think also important first to step back and think about, how likely is it that someone actually does have an SUD, and remembering that, I think about this diagram on the left, most people have used some kind of substance, and only some of those kind of go on to use substances in a risky way, and only a small subset of that will actually go on to develop a substance use disorder. So kind of just remembering that, again, specifically for me as a primary care physician, when I'm just learning about a patient's health history, that there may be substances involved, and it's my job to sort of figure out if I think it's in that risky use or possibly SUD category. I think, again, as is pretty well known by now, we think that substance use disorders are related to many different factors, somebody's biology, so sort of their genetic makeup, the environment they've been in, of course, the social determinants, the sort of social world they've been exposed to, when they've been exposed to substances, what those experiences have been like, and probably many other factors that we don't yet understand. So we don't have a great way of predicting who is going to develop an SUD. So having a regular way that we screen for folks in our care is really important. So this is kind of one typical way that many may have heard of, SBIRT. And I like to think this is a wonderfully evidence-based way of doing it. But I also encourage people, if you're in a clinic, for example, even if you don't have the ability to develop this entire process, there are lots of ways to still integrate, smaller bits of screening into your care. So I think first, kind of the S for screening. So there are, of course, many different validated questionnaires out there that can be used. So if you have somebody who screens negative, of course, like if you're a healthcare professional, you're just gonna, in so many words, say, doing great, keep up the excellent work and provide them a bit of counseling. If they do screen positive, that's where we're going to ask some additional questions, really to try to assess sort of that level of use, how severe do we think that their use patterns might be. If we think they're sort of just in that risky use category, that's where we might do that brief intervention. So this can be, me as the physician, this might be a trained peer recovery coach, this might be a counselor, this can be any different trained kind of professional and doing, motivational interviewing and trying to do some brief intervention around what that use looks like and arranging some follow-up. And then if that person triages really into that severe use category, then that's really trying to get people connected to treatment quite quickly, as much as you can within your setting. So once we've sort of identified, just think kind of really basic overview of the treatment landscape. And of course, you all here are this treatment ecosystem, so I don't need to dive into the many details of all the ways we can provide treatment, but there are many. But as I think about sort of that, I also like to think about the way that our treatment has evolved based on how we have understood and defined addiction or substance use disorder over time. So certainly if we think back to, before the 1970s, into the 1970s, we really thought about addiction more, right, as a personal choice, a moral failing, which then became a criminal problem, sort of with the war on drugs. And over time, we have, really evolved our understanding to know that, addiction really is a chronic relapsing brain disease, in many ways parallel to other chronic diseases that we treat, certainly in primary care and in much of medicine. And so as we have understood addiction differently over time, right, this has allowed us to evolve our treatment modalities and really offer many more so that we can meet people wherever they are in their needs. And when I think about treatment, I just try to remember that, every person's path is different. And every person needs different types of services. They need different entry points into care. And I really like to think of, these two arrows on the left are how I think of people's trajectory with almost any chronic disease that I'm treating in the primary care realm. And I think substance use disorder very much mirrors this. There are some people, for instance, this kind of straight-ish arrow on the left, if I'm treating somebody for their diabetes, there are some people who get the diagnosis, they completely change their diet, they start exercising, they make really dramatic changes, and they improve their A1C and things go in a pretty linear fashion. However, for most people, they take, I would argue, kind of that lower, more meandering course. Right, they get the diagnosis, maybe they make some changes, they're making some forward progress, but then some stress hits, or they lose their insurance and they can't come to care for a little while, or it's a holiday and they eat a lot of sweets, right, and their blood sugars get a bit worse. And so maybe we go backward a little bit, right, and they eventually are starting to move forward. So just like that, that is how I think about substance use disorder care. And again, as people are on this like looping, winding pathway, we want to have services and care providers who can meet people wherever they are on that pathway, and use those engagement strategies to make sure that we're constantly drawing people back in, even if they disappear for a little while. This is at least what has been historically, and not changed yet at this point, but DHHS, these are sort of the 4 pillars that were outlined recently by DHHS about how, we need to, as an ecosystem, as a country, be addressing substance use disorder. So sort of, they bucket it into these 4 categories: primary prevention, evidence-based treatment, recovery support, and harm reduction. And harm reduction is really where we're going to dive in for the next bit of our conversation here. But before we do that, I like to, again, just kind of go back to this chronic disease model of care, because this is just how my brain works, and I hope that it is helpful for you as well. When I think of each of these buckets, I can think of sort of in the SUD category and in that chronic disease diabetes model. So, right, when we're thinking about primary prevention, right, this is like stopping something before it ever even starts, right? So a million ways to do that in the SUD landscape. And again, probably many of you are engaged in the primary prevention part as well. When I think about this for diabetes, right, this is, me as a provider giving, somebody who doesn't yet have diabetes education about how to support their metabolic health, right? Good nutrition, good exercise. Then if somebody gets diagnosed with diabetes, I'm moving on to my evidence-based treatment. And so that's where I'm starting to offer medications, and again, continuing with those lifestyle changes. Very similarly in the SUD world, right, we have evidence-based treatment to offer. Again, from the medical standpoint, thinking about things like buprenorphine, methadone, medications for alcohol use disorder, or nicotine cessation. Those are the FDA-approved medications that we have available to treat substance use disorder. And then moving on to harm reduction. This is, in medicine, we might also consider this sort of like tertiary prevention, right? This is the prevention of complications. So these interventions here, diabetic shoes, eye exams, helping protect the kidneys, right? These are no longer, they're not trying to treat or cure the diabetes. These are trying to keep somebody as safe as possible, while they continue to work on the primary management of their diabetes. Very similarly, this is how I think about when I counsel about harm reduction with patients, right? I am just trying to keep them safer when I'm in that mode. It doesn't mean that they have to stop using. So I'm talking to them about what kinds of safer use practices they are doing. always offering naloxone, and importantly, like educating people on use, making sure that the people around them know how to use it. And then the other pillar that SAMHSA outlines for theirs is recovery support, which of course there is some parallel for some chronic disease support groups as well. So let's move on and talk a little bit more about the details of how I imagine that we can integrate harm reduction practices into our clinical setting. And again, this has nothing to do with actually giving out any harm reduction supplies. This is just a philosophy, a principle, and counseling that we can do. So just kind of going to, I think it's important right now, especially in the world, to think about really like what is harm reduction, and at its foundation, it's a philosophy and an approach, and there are a lot of different ways that we can carry that out, but it's just at its foundation really this approach. So approaching people without judgment, understanding that everybody is unique, they have their own goals and values. It's our job really to, give them dignity and respect, whatever their goals and values are and wherever they are in their pathway. Also redefining success for people. Again, with my medical hat, we are trained and we take a million exams about what are the right metrics for every different disease and how should we be, what should everybody's goal be to manage their disease. And this is really a time where it's important for me to know what my medical metrics might be, but I also need to know what is success going to mean for that individual person. And that's going to be different for everybody. Again, the minimizing harm piece, though that gets sort of to many more of the specific strategies for people to use more safely. And then just always empowering people with knowledge. And to me, that's even empowering people, not just with knowledge about the substance or about their treatment options, but also even just about how to navigate and advocate for themselves in the medical and the social service systems, right? Going back to all of those mistrust pieces, like there's so much that we can do to help people advocate for themselves in the care settings that they're going to be interacting with. Again, in recent years, SAMHSA, the Agency for Healthcare Research and Quality, have all put out wonderful frameworks and advocacy for sort of low barrier practices and harm reduction strategies. So encourage you to take a look at those. And, why do we feel passionately about this? First of all, anecdotally working with patients, conveying this philosophy really makes a difference. I think not only in their outcomes, but truly just in that trust building effort. Conveying a harm reduction philosophy means a lot to a lot of patients. But we also have excellent evidence from around the world that harm reduction practices make a big difference. They decrease the rates of infectious disease transmission, hospitalizations for things like endocarditis, which, infection of the heart tissue, other soft tissue infections. We know that it can reduce stigma. We absolutely know it reduces overdose. And then again, kind of going back to the meat of our talk today, it really can improve trust, engagement, and encourage people to enter other forms of treatment over time. Many ways to enact harm reduction, of course, and these have been in the news. Everybody, I think, is familiar by now. Overdose prevention centers, the most notable in the US, really being the one in New York, and I encourage you to look at their website, and they have an ongoing metrics of how many overdoses they have reversed. Syringe service programs, and we have wonderful ones here in Michigan. Obviously naloxone distribution, drug testing strips. And then where I really want to focus today for the rest of our time is kind of like on the clinical encounter, because I think this is an area that's neglected and that we can do a whole lot more in the harm reduction counseling space here. So some strategies for doing that, and I'm going to do that just illustrating using a case. This is a patient of mine back in Seattle with a couple of details changed. She was regularly accessing our syringe exchange program at the time when I was working with her. She is a 29-year-old, and she showed up, and at that point she was living intermittently with her friends, oftentimes though sleeping in a car, occasionally in a tent in downtown Seattle. She's injecting fentanyl many times a day, often combined with methamphetamine. She had had many overdoses. She had had some hospitalizations for abscesses and for endocarditis. She didn't know of any medical conditions, wasn't on any medications, but because she had been not really feeling trusting of the medical system, she hadn't really been getting any kind of regular screening or checkups to know if she needed any medications. So when I'm thinking about my interaction with her, I just kind of encourage you to hold her in your mind, or another client or patient you've worked with as we work through these different strategies. So again, using that person first destigmatizing language. This is my own chart that I've built over time, but there are a million versions of these out there. Really do encourage you to just have this available, have it there for your teams, for your administrative staff, right? So that this can just become the standard language in your care setting if it's not already. And I will say, certainly in the clinical realm, I think one of the easiest places for this to pop up really is in drug testing. So that's a place where I try to really monitor my language as well. But all of these can be utilized. Second thing I'm trying to always make sure I'm doing is, again, eliciting and aligning with her goals or with whoever the patient is, right? And again, from my just sheer medical standpoint, my goal, of course, is for that person to not use any substances and live a long and healthy life. For some people, that is going to be their goal, but there are many other goals out there, and these are just some that have been shared with me over time. Some people want to decrease their use and use more safely, but not completely stop. Some people very much do want to stop all of their drug use. And oftentimes I try to ask people, if their goal is, usually their stated goal is something related to their substance use, but I try to really find out what's behind that goal, right? It's important to decrease drug use because, and oftentimes underneath of that, right, is something like regaining my self-worth, calling my family, seeing my kids, feeling more safe and stable. These are all things that people have told me over time. And so really eliciting even the goal that's underneath the substance use related goal can help us better align with our patient and help motivate and encourage them. Asking explicitly about people's safer use strategies and providing education if that's needed or if you feel comfortable doing that. And I have often learned some of the best tips that I share with patients later, I learn from patients. So I love asking people this question. And I'll often sometimes I'll just say, how do you help keep yourself safe generally? Or I'll ask them if they have a source for any safer use supplies if they need them. Encouraging people to test their drugs for fentanyl and xylazine, doing things like test doses, alternating injection sites if they are injecting, switching from injecting to a different route of use, encouraging people not to ever use alone if they are going to use. And there is, even an app for people who are socially isolated, an app that people can use where they can call and someone's there available on the phone, who will then call 911 if the person doesn't respond again in about 10 or 15 minutes. So these are, different conversational points that we can engage with patients on over time. We'll, of course, be prescribing naloxone and giving that education on use. Again, by now, most people are pretty familiar with it. And the mechanism of using it, of course, is not very complicated, just a nasal spray. But part of that education is, how to identify an overdose and then making sure that their family, friends, or whoever might be around them actually knows how to do that. Empowering people with knowledge. I think this one is really important. And, a lot of people, of course, who are using substances are honestly much more savvy about the drug supply than I can be as a medical professional. But we can still offer a lot of, helping people understand what their treatment options are. How do these different things work? How will they impact their life? So again, if with my medical hat, this is often talking about the medication realm, but depending on your setting, might just be, helping people really understand what do different residential centers mean, or what does transitional housing mean, and what might be a good fit for them. So just again, giving them as much knowledge and encouraging them to ask questions as much as possible, since people often won't feel empowered, especially, feeling like they are in the setting of a, authoritative physician or, somebody that they feel like they may not be able to ask questions to, really encouraging people to do that. If you can, providing drug testing strips and encouraging people, making sure that they actually know how to use those. And specifically right now, I really encourage people to do this, not so much for their opioid. Most people at this point know that their opioid is fentanyl, but actually testing for fentanyl in other substances. So if, they think that they're using only cocaine, making sure that they're testing that cocaine, since fentanyl is sometimes showing up there, and that's usually where people are getting surprised. And these are just some open educational materials that we'll talk about those drug testing strips. And then, again, if you're a medical provider, or even if you're not, referring people to get medications for opioid use disorder, again, really without contingencies or additional requirements. Sort of more historically, right, people often needed to do multiple intakes or engage in counseling before they could be started on something like buprenorphine. We now know that rapid access without requirements is very much life-saving. So, if you're able to offer that yourself, going ahead and doing that, otherwise quickly connecting patients to care if that's what they're interested in. And then connecting people to other harm reduction resources. Oh, sorry, I think I forgot I was going to talk through this, but just again, sort of thinking about the way that, we're providing that buprenorphine or methadone, but buprenorphine being the more available option. Just kind of, trying his best to offer same-day access if you can, getting this medication to people in the settings that best meet their needs. So sometimes, right, that means trying to get it out into mobile locations instead of asking a patient to come to a clinic. Again, not requiring behavioral health services, but, offering them so that people have that option. Flexibility with medication and making sure that people know they don't have to taper off immediately, since a lot of people have thought of an agonist medication as just a brief sort of detox type of medication. And then, really being willing to continue that MOUD based on that person's clinical benefit, which to me means, some amount of stability, they're using more safely, they're progressing in their life, their functionality is improving, versus saying that they have to be abstinent from all substances as the metric. So then finally, of course, connecting people to harm reduction resources that are available in the community. Some are available mail order, but there are also, wonderful resources here in our own community and all across Michigan as well. So I know since we can't do full participation, just, encourage you to think through with Alicia, like a couple of things that you might offer to her or things that you might do in your encounter with her. Even if you don't have a lot of time, just sort of thinking through one or two things that would sort of align with this harm reduction philosophy as you interact with her. And so for me, I'm going to be, asking her about her goals for her use. Is it to stop? Is it to use more safely? Is it to stop her opioids, but maybe not the methamphetamine? Where is she with those? Asking her how she's keeping herself safe, and then, sharing some tips and strategies if she's open to that conversation. Giving her naloxone and making sure that she knows how to use it. Giving her drug testing strips, and again, encouraging her especially to be testing her methamphetamine for both fentanyl and for xylazine. I'm gonna, let her know that there are a lot of treatment options out there. It doesn't have to be medication, but that certainly medication is highly evidence-based and the gold standard, and that I'm open to offering that to her without other steps that she has to take first. And then I'm gonna, be trying to connect her. I work in a federally qualified health center, so it's always at my forefront, but to some kind of medical setting, right, so that she can get all of her general medical needs cared for, and to any other community resources, whether that is, peer support, whether that is, recovery support of some other flavor, meetings, transitional housing, etc. And these are just, I always like to end on kind of words from patients. I shared, stats that harm reduction makes a difference in people's lives. But to me, the words from patients are the most important part. So just a few things people have said over time, wow, I've just told you a whole bunch of things I've never said out loud. I've never been somewhere I can say things so honestly. I get a smile on my face every time I walk in here, which I will say for myself, I certainly don't get a smile when I walk into a medical setting. But this patient was particularly optimistic and happy. Somebody else who said, I love coming here. I know you guys really care about me. You guys really changed my life. Nobody else has made it easy to get treated. And I'm thankful and grateful for all the compassion that you've had my whole journey with my sobriety when I came to you very scared and very lost. And so again, this is, I think probably for all of you, you get to, hear some of these words from patients over time, right? This is really impactful work for many people in our community. But I think as much as you can, sort of adopting some of these strategies and making this philosophy clear to patients, it, builds that trust and lets people feel like they can be honest and sort of bring their whole selves, which then allows us to provide the best care that we can to them. So I hope in summary that number one, it's clear, we have lots of evidence-based care out there, but we cannot even begin to engage people around it unless, we can build that trust with a population that historically is going to feel a bit of mistrust in our settings. We certainly don't know if we don't ask, so figuring out what kind of screening method works for you personally within your professional setting. And then finally, just that whatever our setting, we can all incorporate, some of the harm reduction principles and practices into our interactions, whether that is super brief or whether that's a longer counseling discussion. So I hope that, you'll consider maybe one change, one thing that you can do in your own care setting that might sort of contribute to moving in this direction. And with that, I am very happy to take thoughts, questions, other insights from folks.
So the first one of those is how to handle someone who denies substance use.
Oh yeah, absolutely. So I think oftentimes, and I'm presuming behind this question is that you sort of as the clinician or whoever the professional is, thinking that that person probably is using substances, but is not yet sharing that they are. And so I think, to me, that's first of all thinking kind of what's behind that, what is that person's concern? Why are they not feeling like they can be forthcoming? And I think there can often be many reasons, but one that I hear very commonly, and a patient last week who was incarcerated for 25 years, he told me that, at our first visit, he absolutely lied to me about, what substances he was using. And he said at that point, for 25 years and his whole experience in the correctional system was that being honest about what was going on with him always got him into worse trouble. And so it was his reflex really to not share with me initially. And it took a little while of us getting to know each other and him trusting that I wasn't going to, discharge him from care if he shared that he was using substances. So that's just one example, but I think always thinking about like what is potentially behind that person not being willing to share that information. And if it's a trust issue, which it oftentimes is, just taking the time to try to build that trust, and that may take a few interactions with that person to make that happen.
Okay, so I think we had someone with their hand raised. Sonia, you should be able to ask your question. If you're unable to unmute, you can also put it in the Q&A, and then we can get to it in the we can go through it. But if you are able to unmute, go ahead and unmute. So the next question go ahead, Sonia.
Oh, okay. Are we looking at starting earlier with, educating children because they're starting earlier and earlier with substance use? Are we looking at going into even elementary schools because we have older brothers and sisters that are already using? So I think for safety's sake, we should go try to get earlier, and I mean even kindergarten, because I had a young man tell me he was 8 and his father encouraged him to use. So it's getting
Yeah.
scarier and scarier.
Yeah, thank you so much. I think that's sort of a comment and a question, and it's a really important
Yeah.
one. So yes, I think, there are efforts to try to do that, certainly in some schools more than others. Speaking from the healthcare provider standpoint, when I have what I call a well child check, right, where a kid comes for their annual visit, certainly as kids like enter that era of time, or if I know the family and I know there may be substance use going on, I do try to ask about it and counsel kids about it. Or, I'll ask kids like what's happening with their friends, right? Sometimes kids might not want to share that they've tried something, but they might be open to sharing that maybe their friends have and they're
Right.
worried. So I try to bring up those conversations, especially in the teenage sort of well child visits. And then I think, your point is so well taken that I'd say almost all of my patients that I see initiated their substance use in their teen years, some even younger, and very oftentimes related to a parent or a family member providing that substance. So I think very much that early education with kids, even just, if there are, pills around the house, don't try anything that's around the house, right? If you find something on the
Right.
floor, just be careful not to do that. So yes, enormous. And one last piece I'll chime in. It's obviously such an important topic, so thank you for bringing it up. I think there are more and more products out there, such as like kratom type products that are available in convenience stores. They look and seem very safe, and that's something that I'm seeing both adolescents and adults start using and not realize that over time it actually can have sort of an opioid-like effect and people can become dependent. So also I'm trying to ask kids a lot more and counsel about, avoiding all kinds of things that are, marketed as energy supplements and mood boosting supplements, because a lot of those end up having similar properties to opioids as well. Thanks. I think Corey, hi Corey. Corey raised his hand.
Let
Oh,
me get
can you
him.
unmute him maybe? And actually, while you're working on unmuting him, I see somebody also wrote in a question, does the spray work with fentanyl? And I'm going to presume that's talking about the naloxone spray. And the answer is yes. Yep, it will work with any opioid that is in the system. So one thing that can happen is with the rapid action of naloxone and the very long time that fentanyl sits in the body versus something like heroin, it can actually, the naloxone will work. But then after a couple of hours, if the naloxone sort of dissipates from the body and the fentanyl is still there, a person can, sort of, for lack of a better word, re-overdose. So that may be part of what's embedded in that question. So a person may need, it's more important that the person get medical attention, not only get the naloxone by a family or friend, but actually get to medical attention so that they can be monitored. Yes. Maybe,
Corey,
do we,
you're
are we unmuted?
Yep.
Can you hear me now?
Yep, absolutely.
Yes, we can hear you.
Okay, good to see you, Liza.
Hi.
I was wondering if you could talk briefly just about the role of peer recovery coaches. I know you talked about it just for a second, but just in-person centered care, but also harm reduction, and them, like peers being able to speak patient language regarding their substance use and just how important they can be in clinical settings.
Yes, thank you. I mean, I think you should probably talk about it, but
No, that's all right.
I will talk about it from my standpoint as a physician. And I will say that, yes, if you have the ability to have a peer in your team, whatever your environment is, absolutely 100% do it. And when we say peer, of course, meaning somebody with lived experience who has some additional training about how to use that experience therapeutically and connect. So yes, and this is, I mean, to me, this feels like it's always my crutch as a physician. If I have a peer and I have a patient who is not trusting of the system, the peer is like my in. And this, happened for me a lot when I was working back at a syringe exchange program. People had automatic trust there because everybody but me had lived experience. And so that connection was strong. They, as Corey alluded to, use a whole different set of language than I'm using as a medical professional. And absolutely that was a trust bridge. So I think enormously important if you can possibly do it. And there are, now mechanisms to bill for peer work. So cannot emphasize enough that if you have the ability to do that, absolutely please do. But also want to emphasize that even if you're a clinician that somehow you cannot have access to a peer, there is a lot that you can do to build that trust. But yes, a peer can work magic in that way.
Okay, our next question from the Q&A was, I work in probation and some flat out say I have no desire to stop using. How do you as a medical professional approach this?
Oh yeah, great question. So yeah, I think to me, this is, again, this is going to be an over time conversation. If the patient's willing to engage more on that first visit, I will, try to do some more motivational interviewing. Again, if I feel like I've already established some baseline trust, but I think my first step would be making sure that I already have a good rapport and trust built with that patient before I try to push on it at all or learn and question question it anymore. When I do feel like I've had that trust, that's where I will often try to do more of that motivational interviewing. So, questions like, have you ever noticed any problems or any downsides to using? And, what are the things that are great for you about using? Like, what are you getting from it? Those lines of questions I will try over time. And then again, when I feel like I have a strong rapport, sometimes I will, explicitly say, my job is to take care of your health and I really worry about your substance use. Is it okay if I share with you some of the reasons why I worry about it? And again, once trust is there, I find people are responsive to that. I think if I lead with that, that's often not very helpful. But again, in that overtime conversation, I think that can be a helpful route as well. Yeah, and if anyone else has suggestions to that, I'm more than happy to learn.
The next one from the Q&A. So from a clinical standpoint, I oftentimes have a hard time coordinating care between my clients, PCP, and myself. My clients often tell me that their doctors do not listen to them, or they are scared that their doctors will take away all meds that would help them in an emergency situation. For example, if someone is abusing kratom for energy and not an opioid, but they have to have surgery and will not go through with it because once labeled a substance user, they no longer qualify for pain meds. Any advice or feedback on this?
Yeah, so, and I'm guessing maybe this is like a social service provider, but I think, yes, a lot of things. So yes, I think this is common and it's real, right? And that's part of why we're trying to do presentations like this to as many healthcare providers as possible, because people are rightly afraid that that their physicians are going to stigmatize them, say that they can't ever have pain medications because they, once used opioids, or say they could never have their ADHD treated because they've used, or that they won't ever be able to get surgery because they've used, right? And these are very real concerns. And I think over time, certainly medical professionals being trained now are certainly understanding addiction as a chronic disease and being taught that. But I think, even my generation and beyond, certainly we're not taught that. And a lot of these practices are still in existence. So it's a real and valid concern, I think, for patients to express that. So I think, one approach certainly that I try to do is counsel them a little bit about, if they feel like they can try to gently have a conversation with their patient to learn a little bit more about like whether that, like how that provider might respond to them sharing. And, if they really feel like they're with a provider that they can't trust, I would empower them to try to find another medical provider, if that's a possibility. And then just, letting them know that, again, it is, if they are willing to open up to a medical provider, that is the way that provider has the potential to provide them the best and the safest care and help them with their health. But I think it is very real that people want to be cautious how they share and where they share. And I definitely understand that. So that's not a very great question, a very great answer to a really important question. But I do think as medical professionals get trained differently over time, I think that will become an easier conversation. But it is a really valid concern for patients.
Okay, one final question. Is the Bali one shot more effective than the spray? So it was BALI.
Only one. I honestly don't know the brand name of that one. I'm assuming that's a certain type of a naloxone formulation. If it is another kind of a naloxone formulation, I'm guessing as long as it is naloxone, then it should be this. Oh, and I'm guessing, right, this is like an injectable form of naloxone, I presume. And if that's the case, injectable versus spray, they're both highly effective as long as it is that naloxone medication within there.
Okay, and we are at 1 o'clock. So thank you again, Dr. Hutchinson, for your presentation today. And as a reminder, everyone who attended will receive a follow-up email with the CE information in case you did not get that when it was on the screen. And thank you again, everyone, for attending, and have a good rest of your day.